Retatrutide is years away from FDA approval, and yet the fight over access, price, control of this medication is already well underway. That's what this podcast is going to be about today. There's well over 100,000 people, by my estimates, who are already on some form of this medication today, and that should tell you enough about how disruptive this molecule is and will be. It is a game changer among game changer. We've been talking about it for 3 years here at On the Pen. Well before any of your favorite gym bros were talking about Retatrutide, we were talking about Retatrutide here at On the Pen. And that's because we identified this triple agonist as a game changer among game changers. So this is going to be a very Retatrutide heavy episode. And so I hope you'll join us and stick with us if this is a topic you enjoy, because I think this is really going to effectively lay the groundwork for what accessibility to this medication will look like. So let's get into it.
Welcome to the On the Pen podcast with your host, Dave Knapp.
Welcome to the On the Pen, the Weekly Dose podcast. This is our weekly roundup in incretin mimetic news, and frankly, there's no news that is bigger than Retatrutide news. Just find me any news that is bigger than the data that we got on Retatrutide. Now, we already did a video about the Triumph phase 2 clinical trials that we got in osteoarthritis of the knee. You can go back and check out that video if you'd like more data. So we're not going to super rehash the data. We'll go over at a high level what the data showed us. We're not going to go over how the medicine works, because by now we all know that it's the triple agonist, right? If tirzepatide was the dual agonist, GLP-1, GIP, Retatrutide is the triple agonist that adds to it a glucagon component, which is absolutely just shredding liver fat. It is absolutely revving up people's metabolism and showing a tremendous amount of weight loss. So let's get into what the weight loss looked like in this first trial, because there are longer obesity trials where the primary outcome is the weight loss. This was, again, a specific trial in measuring pain reduction in folks with osteoarthritis of the knee. But check out these numbers. These are placebo adjusted, meaning it's taking the 2% out that people lost on placebo. But looking at these numbers, folks on 1 milligram over 48 weeks lost 17%. They bumped up to 4 milligrams. Those folks lost 22%. So right there at the lowest dose, you're already reaching the efficacy of today's drugs that are on the market, like tirzepatide and semaglutide in their various forms. If you bumped up to 8 milligrams, you saw 24% placebo-adjusted weight loss, and at 12 milligrams, 26.4% weight loss. Adding back in that 2% of the those on placebo loss, that's 28.4% weight loss in these 48 weeks at the highest dose. Now, when you adjust for some of the more real-world outcomes, you kind of ding the numbers a little bit based upon people who quit the drug, etc. Those numbers look more like 20% weight loss and 23.7% weight loss at the highest dose. But even then, you're still seeing a drug that is better than the current drugs that are on the market. Around 48% of patients on Retatrutide lost greater than 25%. And then if you were at that 12 milligram dose, that highest dose, patients lost 59% of patients lost more than 25% of their body weight. There was a subset that lost 30% of their body weight, and some even over 35% of their body weight on Retatrutide. So the lower doses compete with today's best drugs, and the upper doses are entering into bariatric surgery level weight loss. And that's putting the whole obesity system on notice, and probably a lot of surgeons nervous, because typical body weight loss with something like the sleeve gastrectomy, for example, is about 18 to 25% body weight. The Roux-en-Y gastric bypass, 25 to 35% weight loss, or the duodenal switch, 30 to 40% weight loss. So the upper doses of Retatrutide overlap with sleeve and bypass outcomes without any surgery. It's incredible. It is a game changer among game changer. It is the new benchmark in obesity medicine. And there's actually more data, like I said, landing in later 2026. The longer duration will historically, if history is a marker, equal more weight loss than we even see here at this 48 weeks. We have an interview that will be airing later this week on our channel and on our podcast with our friend Mimi from Australia, who just wrapped up her clinical trial on Retatrutide. They ended it like 10 weeks early on her, which was a huge bummer to her. So we're going to hear from her because she had to end abruptly. We're going to hear her story, a incredible story. She's one of those folks that got up that 35% body weight loss in the time that she was on Retatrutide. So this is just showing you that these drugs are not simply a alternative to bariatric surgery. We are approaching a point in time where these are on par with bariatric surgery. And as people are on this Retatrutide trial, you see that these numbers aren't plateauing either. So we will see stronger weight loss numbers the longer that these folks are on this trial. And I think you'll see some of those numbers in that population of folks on the higher doses eclipse maybe even some of what we see with some of these bariatric surgeries. But the real story that I think is taking shape here is not in how powerful Retatrutide is, because we've literally been expecting or anticipating this kind of data for more than 3 years at On the Pen. We've been talking about this, and I think that's sort of reflected in the fact that you didn't see this massive spike in Eli Lilly stock. Wall Street was expecting this as well. So it was on par, I think, with expectations, but the expectations are astronomical compared to previous options that were available to patients. And all the innovation in the world, all of these drugs, we talked last week about WVE-007, the James Bond of weight loss that targets fat. Not only targets fat loss, but it also targets the promotion of building of lean muscle mass. We're talking about an insane future in obesity medicine, but none of it means anything if people can't access it. And that's really where we are today in terms of ensuring that there's going to be an option for everyone. And that's sort of what I want to get into today, because Lilly wants Retatrutide or Retatrutide to be classified as a biologic. So not a traditional small molecule drug like you've seen every other incretin and nutrient-stimulated hormone treating obesity on the market to date. They're trying to get this classified as a biologic. Now, we talked about this before on the podcast. That matters in three major ways. It affects the exclusivity length of time that a pharmaceutical company has on a drug. It goes from, I believe, 5 years of market exclusivity to 12. It affects compounding rules because biologics cannot be compounded. And then that gives the pharmaceutical companies a tremendous amount of pricing power in the marketplace, because essentially there's no competition, and there's no competition for a long time. But this whole argument about getting this classified as a biologic is not about safety. It's about protection. And we're going to get into it. So let's explain this here. This is why Retatrutide really is not a biologic, arguably. So biologics are large proteins. They're hundreds of or even thousands of amino acids grown in living cells that are sensitive to tiny manufacturing changes. Retatrutide is a short-chain peptide. It's chemically synthesized, and it is below the traditional biological size thresholds when it comes to how those things are defined. We'll just leave it at that. So even though it acts like a biologic in the body, it's made like a drug. It's made like a small molecule drug. And if it's treated as a drug, they get, like I said, 5 years of market exclusivity. Now, really a lot of confusion around what this means, but essentially the first 5 years of the life of a drug, the patent can be challenged for a number of reasons. We've seen patent challenges right now are going on in the courts for both semaglutide and tirzepatide. But these companies are guaranteed that 5 years of market exclusivity, no matter how those patent lawsuits shake out. That 5 years jumps to 12 years with the biologic. So ultimately, there's no biosimilars that are allowed during that 12-year window. Again, with tirzepatide and semaglutide, it's 5 years. They could lose their market exclusivity within 5 years of the release of the patent. 12 years with a biologic. So if they lose their patent challenges on tirzepatide, they still have some time left on market exclusivity for the drug. They likely will not lose those, but that jumps to 12 years. And I think the most important thing to understand about the reclassification of retatrutide to a biologic would mean that 503A and 503B pharmacies are effectively locked out of compounding this medication. 503Bs would have some latitude, arguably, but they would face extreme barriers. Routine compounding becomes legally and technically restricted because biological status doesn't slow compounding down. It actually shuts the door, or almost completely shuts the door. So biologics not only would allow Lilly to have longer market exclusivity, no compounding, but it would allow them to command a higher price in the marketplace because they get this designation, and there's an assumption when they bring this to market that they're harder to manufacture, that they're harder to copy, that there are fewer negotiating alternatives for payers, so they can command a higher price with the insurance companies. And the price pressure stays muted for much longer because, again, you don't have those pressures of compounding. You don't have the pressures externally from lawsuits that could end your market exclusivity in that first 5 years of the drug's existence. So there's just a lot of price pressure upwards on a biologic compared to a normal small molecule drug. And when there's no credible alternative or backup option, which to retatrutide there wouldn't be, it would be the first drug that has bariatric surgery level results, the prices won't come down. They'll command a massive price and the prices won't come down. So let's talk about where this currently stands, because ultimately the Eli Lilly went to the FDA. We've been covering this for well over a year, maybe close to 2 years now, a year and a half at least. Lilly went to the FDA. They said, we want this classified as a biologic. Here are the reasons why. The FDA initially said, no, we're not going to do that. So Lilly challenged that decision in court. So the point that we're at today is the court told the FDA to reconsider and better explain itself. So the first no given to the FDA to Lilly didn't stick. The courts looked at it and they said, you need to reconsider your decision, and you need to explain your decision better to Lilly. So ultimately, we're sitting now at the point where the court has made its decision, that the FDA has to go back, and now we await basically what the FDA has to say on this. But if this thing is classified as a biologic, that would be a massive, massive loss for patients. Now, again, we're focusing on the accessibility of this drug into the future, and I think that this is an important conversation to have. One of the interesting points that I have to bring into the conversation is the fact that I got to sit in on a closed session question and answer with the media. I didn't get to ask a question at this time, but shortly after the Most Favored Nations announcement with Eli Lilly and the Trump administration in the Oval Office that day, there was a press briefing that I was invited to. Dave Ricks was asked by Max Bayer, reporter of Endpoints, who we've interviewed here on this very podcast. And he was asked, was retatrutide included in the Most Favored Nations discussions? Meaning, will we get a cash pay version of retatrutide that is, circumventing the PBMs? Will we get these cheaper prices? Will it be $250 also? And there was a hard no. No, that was not included. That was not part of these discussions, even though what we heard from the Trump administration was that these companies that were jumping onto the Most Favored Nations agreement were also agreeing to offer future drugs at Most Favored Nations pricing. Now, was Lilly saying that, no, they're not going to offer it at it wasn't part of the negotiations in terms of the price points that they had discussed for tirzepatide? Maybe. Or did it mean altogether there won't be a cash pay option of this medication? I don't know. That we would love to get clarity on, but I highly doubt we're going to get any more information than necessary at this point in time. So retatrutide is being positioned to be a drug that, and well so, should be offered at a premium. This is a drug that is far exceeding the current drugs that are on the market. I think that we're going to see even the indications of retatrutide far beyond simple obesity. But it is going to be their crown jewel for the next decade, more than likely. Retatrutide is going to be a massive drug, and so they're attempting to build a moat around it. And these are things that we need to be aware of as a community so that we can hold our positions in conversations about these and basically, be able to articulate to people in positions of power, like, this is an important thing to us. This is an important thing in the advocacy of obesity and sort of the next frontier of the fight of accessibility, which marches on each and every day. Because, of course, the current drugs, while as great as they are and as much as access is expanding, there are still people with sicker or rather more advanced versions of metabolic disease that are going to need these newer treatments. And price is going to be a huge factor. So let's talk about the gray market right now, because I think it's also nearly impossible to talk about this topic without including a discussion about the gray market, because there are, as I mentioned at the outset, hundreds of thousands of people on this medication already. So research-grade retatrutide exists. It's in the gray markets of the internet. It's where people are going and they're buying, basically versions of these peptides that are made in factories overseas. They're being imported into the United States, oftentimes illicitly, in shipments that are marked as something else. The FDA's tried to crack down. There's no doctor involved in this. That's why it's called the gray market, right? So it's not a prescription medicine, but the demand for this is massive. And all you have to do is really scroll your TikTok for about 15 minutes. You're going to come across an insane amount of content on the topic of retatrutide. An insane amount and oftentimes, what I find most disturbing is oftentimes it looks like very young people taking Reta. Crazy. It's crazy, but the demand is massive, and there's a whole gray market for it. Proliferating over on TikTok and in the far reaches of the internet. And I would estimate that tens, if not hundreds of thousands of people are already or have already used it. And I think it's a testament to the effectiveness of this drug. It's also a testament to the fact that there needs to be more guardrails, I think, around this stuff than there currently is. Because gray markets appear and they thrive when legal access lags the reality of the demand for the medication. And you saw this earlier this week as we launched a petition to fight back against the Safe Drug Act of 2025, a drug act that is in theory designed to put guardrails around compounding, but in practice, I think, is creating a new battlefield for Eli Lilly and Novo Nordisk to shut down compounding on the current classes of medications, which is why we as a community need to be loud about our opposition to it. If they were really concerned about the safety of compounds, they would do two very simple things. They would require reporting around the active pharmaceutical ingredient of a compound. Patients ought to be able to know where the actual source of their medication is coming from. And they should know that those places are FDA approved and inspected. And the second thing is they should require adverse event reporting. Those are required of 503Bs. They should be required of 503As as well. 503As are making a tremendous amount of money. They are making thousands and thousands of these scripts. So when there are adverse events, they should be required to report those to the FDA. Simple. None of that is in this bill. None of it. Instead, it seeks to put caps on the amount of compounds that can be made by a compound pharmacy without them having to report to the FDA. And then it seeks to codify the definition of essential copy. Again, all of these things that will become law and then argued in court, and then a battlefield for Lilly to potentially win a legal battle and thwart compounding. It's creating a new battlefield for them. They're losing in the courts. They're losing with the current language that exists in the Food, Drug, and Cosmetic Act. So we create new language. We create new law. Just vague enough to pull some threads and hopefully win something in court. That's how I see it. You may see it differently. If you do, curious to hear from you. But if you want to fight back against this legislation, you can go to otplinks.com and fight back against that piece of legislation, because I think that we need, as a community, to have our voices heard on this, especially those who have gotten healthier by way of compounded medications. So the rumor on the gray market, to get back and close the thought loop here, There's been no specific FDA cutoff announced, but what the rumors going around are that the compounded versions of GLP-1s, especially obesity medicine in the gray market, are all going to turn off like a sieve on January 1st. Now, I seem to feel like this is probably more of a marketing tactic by these companies to sell a whole bunch of peptides at the end of the year. I think that's probably creating some panic and probably panic buying on people's parts. And so these companies are benefiting greatly. Again, that's why there should be guardrails around this. There's no guardrails around this at all. I mean, at the end of the day, they can say whatever they want to say, so long as they cloak everything in research grade. And these rumors proliferate around, and people spend tens of thousands of dollars. I've heard of people having 20 years worth of Retatrutide in their freezer. Why? For what purpose do you need that? So just a massive amount of money made in this gray market. And that's not to knock people who use it. I say this all the time, but I think it's worth qualifying the statement. It's not knocking people who use it. I get it. But at the same time, we're talking about an industry there's no altruism here. They're in it for money just as much as Lilly is, except they have actually done nothing in the way of advancing medicine. They've just taken intellectual property, copied it, and sold it to you with a label that says, don't put this in your body. So you know where I stand on the gray market. I've heard from many people who've been injured by gray market stuff. It's just what it is. It's the gray market. You're taking your health into your own hands. Please, whatever you're doing out there, as risky as it may be, please involve your doctor and let your doctor know what you're doing so you can be monitored for the things your doctor believes you should be monitored for if you're using this. But this all underscores, again, the need for accessibility to these medications, right? The need for us to be aware of the fact that a moat is already being built around the most advanced metabolic drug in the pipeline. And we just need to be aware so that when it comes time to fight, we're all ready and informed. And that's what this podcast is serving to do. Before we jump into the next topic, I do want to thank our sponsor. Our headline sponsor of this podcast is a company called Shed. Now, if you are looking for access to care for obesity, then look no further than our partners at Shed, who believed in this podcast enough to help us do it full time. You can go to tryshed.com and use code OTP25 to save 25% at tryshed.com, where you're going to get connected to a doctor who will, when medically necessary, prescribe medication to treat your obesity. You also get access to coaching. You'll get access to all sorts of medication, whether it's the branded or the compounded versions, depending on your specific situation. All of it is available at tryshed.com. They use one of my favorite compound pharmacies in the game, Strive Pharmacy, which I've gotten the chance to dig into on my own. I really love what they do there. They're a 503A that functionally operates a lot more like a 503B, and I think that they're doing great work over at Strive Pharmacy. They partner with Shed. So I just love this. And when we were looking for somebody to offer compounded versions, I wanted to make sure that I trusted the pharmacy. People always ask me, Dave, who should I go to? I'm like, the pharmacy matters more than anything, because you want to trust the source of your medication. So tryshed.com, use code OTP25. Listen, you're going to want to learn about taking any new medication before you take it, learn about the potential side effects, learn about the trade-offs. There's no free lunch, but all of the information that you're going to need, you can find at tryshed.com, and be familiarizing yourself with all of your options there. So thank you to Shed for being a wonderful partner here at On the Pen. Now let's talk about some data that dropped. We're talking about accessibility and all of the sort of advancements in the world mean very little if people can't access it. That's why I think this data that dropped this past week from our friends over at Roe is absolutely game-changing data. So check out this data. Real-world telehealth data looking at 68 weeks. This is looking at patients who were enrolled in their Roe body program and on a GLP-1, specifically semaglutide. Mean weight loss in this study looked at, again, patients in over 68 weeks. The mean weight loss was 16.6% on average. 33% of patients lost more than 20%, and the safety in this study and looking at this data matched the clinical trials. So what we're seeing here is that that care for obesity can be delivered through a telehealth platform at scale and match clinical trial results. So that scalability decides how many people get access. There are not enough doctors out there to serve the over 100 million people in the United States living with overweight or obesity. So when you hear these blowhard doctors online calling all telehealth platforms except their own a pill mill, or as I like to say, pin mill, the data is actually showing something quite different in that this type of obesity care can be delivered at scale through telehealth platforms. It can meet people where they're at and allow people to get care without the shame, without the stigma, without their doctor, just pointing to the door and saying, if you want a GLP-1, get out of my office. I ain't going to get it here. How ridiculous. But these people can go to platforms like Row or Shed or any number of telehealth platforms that are out there and not only get access to medicine, but get access to care. So, of course, not all telehealth companies are created equal. Of course, not all compound pharmacies are created equal. You want to do your homework and all of that. But this is data that shows that this kind of care can be delivered at scale via a virtual platform and show similar results to a clinical trial. I think, and this is peer-reviewed data, and I think that this is just absolutely great news because when we talk about the problem, we need scalable solutions. The old brick and mortar ain't going to work when you don't have enough doctors to serve enough patients. If we want to get life-changing treatments like Retatrutide or tirzepatide, semaglutide, whatever, into the hands of the people who need it the most, we need companies to innovate scalable tech platforms that can meet patients where they are, that can leverage current technologies to find people the care that they need. And in this case, it's access to a doctor, it's access to a platform, it's access to prescription medication when appropriately prescribed. And it can be done, and it is being done. So I think this is great news and will play a huge part in the future. As we talk about Retatrutide, even though it's a year and a half away, maybe a little bit longer, it's already exposing the issues around accessibility and pricing. Hopefully there will be compounded versions available if they're medically necessitated, if there are shortages. We hope that the battleground for that is not already set and won by Lilly before this drug even comes to market. But there are strategies being done to keep people boxed out. But I can tell you that whatever happens with Retatrutide, the future of obesity medicine is in virtual care. And platforms are rising to the occasion. Retatrutide hasn't reached patients yet, but it's already forcing the system to show us, are you ready? Are you ready to deliver bariatric surgery level results at scale to the people who need them? So I am so thankful that you joined me here on this podcast today. Again, we love to talk about Retatrutide. If you're interested, we've been going live every Monday, Wednesday, and Friday at 11 a.m. Central Time here on our YouTube channel, on our TikTok, on our X platform. We're doing that because there's enough news to bring you just about every single day, and we've been doing it for the last couple of weeks. If you've enjoyed it, let me know in the comments of the video on YouTube. Send me an email at davidonthepen.com. So every single Monday, Wednesday, Friday, and then we do a weekly rundown of the obesity medicine news every Tuesday. That's what this is, the Weekly Dose podcast. You can catch this on all of the platforms that you listen to your podcasts on, and please make sure to leave us a 5-star rating and review before you log out of your podcast app. That helps so much. I don't think you guys understand how much that helps. The work that we do here to just train the podcast algorithms, that this one is worth listening to. I hope you enjoyed today's podcast. If you did, drop it a thumbs up, 5-star review, subscribe on YouTube, do all the things. Thank you for being here, and thank you for being the best part of what we do. We will catch you on the next one. Thank you, my friends.